So, welcome everyone to day two. Thank you all for being here. For those of you who might not have been able to join us yesterday, I'm Sam Mello. I'm the program manager here at the Medical Society and our nonprofit Bridging Medicine, and we run the Future of Medicine program. So, before we get started, just a couple of reminders. Make sure your full name is on your Zoom profile so we can count your attendance. We ask that you have your cameras on when our speakers are talking. We love to see your faces. Please be respectful and attentive to our speakers and your fellow students. Keep yourself muted when not speaking, and you can use the chat function at any time to ask questions or answer questions, and we'll do our best to answer each question, time permitting. If you'd like to speak, use the raise hand function, and we'll call on you. So our first speaker is Dr. Peter Yellowlees. He is the CEO of Async Health, Inc., which is a telemedicine company he co-founded to implement and promote the practice of AI-enabled asynchronous telepsychiatry. He's also a distinguished emeritus professor of psychiatry at UC Davis. So I'll welcome Dr. Yellowlees.
Thank you very much indeed, Sam, and it's great to see all of you guys. And I understand you're all interested in, potentially going into healthcare as a career, and I congratulate you on that interest. Okay, I mean, healthcare is a fantastic area to work in during your life. And probably the single most important thing about it is that it's a very meaningful job. And we all sort of think about what do we want to do, and what sort of impact do we want to have on the world, and that's obviously is part of why we make our career choices. And healthcare is really meaningful. You can, when you've been in healthcare, you can always look back on all of the people that you have helped personally, and that you'll have some wonderful stories from patients who you've assisted, or you might be in administration, or you might be in research, but in whatever area you go into. I mean, one of the reasons that people choose healthcare is because they want to do something that is good, and they want to have, be able to look back on their lives and actually, think, hey, I've really done something that was meaningful and that, I'm proud of. So you can't say that about all jobs by any means. But you certainly can if you're in the healthcare industry. So, I think that's a really important point to make. So first of all, I mean, it's really good to see all of you. I'm happy to take questions. It's easier if you just put them into the chat, to be quite honest, with this number of people. And both Sam and I can monitor the chat and then answer the questions from there. And if you do ask a question, obviously make sure your name's attached to it in the chat. The but perhaps I can just start off. Um, how many of you know what is the difference between a psychiatrist, which is what I am, and a psychologist? Does anybody want to answer that one? Okay, Ria?
A psychiatrist prescribes medication, whereas psychologist cannot. Both can diagnose, but only a psychiatrist is a licensed doctor and therefore can prescribe medication.
Perfect. That's a great answer. Well done. And yeah, so the big difference is that psychiatrists all go to medical school, and they're all physicians. And they've all been trained, like every other medical student in every area of medicine. Many of us actually worked in general medicine or in other medical areas before going into psychiatry, so that we have, extensive experience in the whole medical field. And as you correctly said, Ria, we're allowed to prescribe medications. We also can order, all sorts of different tests, and medical tests, radiology, X-rays, things like that. We can do everything that your average primary care physician can also do. And then we have postgraduate training in mental health, or in psychiatry, as we call it, obviously. So we're both physicians, and we have the sort of training that psychologists have, but obviously we're able to do more extensive practice. Um, so it's a somewhat longer process. Um, so so as a psychiatrist, I'll just rapidly run you through what the sort of the training process is, and in particular, what I did. And then, as I say, if you have questions, just don't hesitate to put them into the chat. All right. So the first thing is, if you're interested in mental health, you have to make a decision fairly early on. Do you want to become a psychiatrist, or do you prefer to provide therapy purely? In which case, there are all sorts of other healthcare choices. You can become a psychologist, or you can become a nurse practitioner with an expertise in mental health. You can become a social worker. All great careers. And so you don't necessarily have to become a psychiatrist by any means. And becoming a psychiatrist is probably the most difficult of those particular choices. So in my case, I actually thought about seriously becoming a psychologist. I was really interested in the therapy side of things and had read a lot about that. But then when I did my own investigating about the difference between psychologists and psychiatrists, I decided that actually probably it would be better if I tried to become a psychiatrist, and that I would have a wider range of potential activities that I could do with patients. Um, and so that meant that I had to go to medical school, which I did in London, in the United Kingdom. You can tell that I'm not a native of California. And so I went through medical school. And then I did actually several years working in emergency departments, emergency rooms, and in general medicine, and really enjoyed that. But then you have to do a residency program in psychiatry, just as you would do a residency to become a surgeon or an internal medicine physician. And so in my case, I did a 5-year residency. And I did that, half of that in England and half of it in Australia. And I moved out to Australia partway through my residency, and was able to complete all of the work over in Australia, and ended up being qualified to be a psychiatrist in both countries. Now, one of the really nice things about doing medicine in particular is that you actually can work in different countries and you can travel. And particularly if you are interested in research and you want to go to lots of conferences, or you get to sort of present to other people, you can often go to conferences, as a presenter. And so one of the things that I did at medical school was, and which most medical students do, is that they tend to take periods of time when they travel and they go and work overseas and do some of their clinical rotations in other countries. So I actually went to Kenya in Africa for 3 months when I was a fourth-year medical student, and ended up doing a study about measles in Africa. And it was tragic. It was just awful because essentially I was working in the bush in Africa, a completely different sort of environment than I'd ever been in my life before. And there were literally dozens of children just coming in and dying of measles. And measles, as you've probably heard in this country, is getting worse now. But measles used to be a fatal disease of children. And I have seen personally, dozens of children die from measles when I was in Kenya. And there was very little we could do about it. There's very little treatment available for children once they have severe measles. And so what this really led me to think about, this experience that I had when I was in Kenya as a medical student, was what sort of medical career did I really want to have? Because most people go into medicine and they think, well, I'm going to become a really good clinician and I'll see lots of patients individually and I'll help patients individually, whether you're a physician, a surgeon or a dermatologist or a psychiatrist. Most people go into medicine because they want to help patients, and their plan is just to see a lot of patients and do lots of good work. But what my experience in Kenya taught me was that there was a huge need for research and for understanding why people got diseases. And at that stage, this was, 50 years ago, basically. I mean, not quite that far, say 40 years ago. Um, at that stage, measles was endemic in Africa, and thousands of children were dying from it. And I was just really affected by this, and actually then came back from Africa. And decided that for my career in medicine, I just began being an ordinary physician who saw a lot of patients wasn't going to be enough. And I wanted to do more than that. And I wanted to actually try and work on finding out why people got ill, or how could they best get better. And so what that meant is I decided that I would probably go into an academic career whereby I would do a whole lot of research and teaching as well as seeing patients. And that's actually what I did. I once I'd got my board examinations, I went and took a university job, and by this time I was in Australia, and and then I started doing research, and if you want to read about that, I've got a Wikipedia page. You can just put my name into Wikipedia and look at a lot of my background. That's probably the quickest and easiest way. But so I decided I'd become a part researcher, part teacher, and part clinician. And that's actually a really cool job. It's very interesting to be able to have those different types of approaches to work. Um, and I went into psychiatry primarily because I thought it was an area that needed a lot of work, and that we didn't know a great deal about why people got mental health problems, and that it was an area that was that I thought I could have some sort of possible impact in. With my interests in trying to understand the causes of what was affecting people. Um, so 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 fast forward a few years, and I was actually again in Australia working in the outback. And I don't know, have any of you been to Australia? Just put your hand up if you have. No? Okay. So imagine I was working in the middle of Australia. Australia is a huge country, and it's about the same landmass as the whole of the United States. But if you work out in the middle of the bush in Australia, um, have any of you seen the TV? I think it's a Netflix program on the Flying Doctor service. No? Okay. Well, there's a Netflix program about the Flying Doctor, and they literally have flying doctors that are sort of, go out to very distant farms all around Australia and very distant places. Well, I was involved in that, and I used to be a sort of flying psychiatrist. And I would get also phone calls from people who were, 100 miles away from the nearest town, who maybe were drunk or who were suicidal, and and the area that I was responsible for as a single psychiatrist actually had the same landmass as California. So imagine if you have got one psychiatrist for the whole of California, okay? I mean, so that was the size of the land that I was my sort of area of responsibility as a single psychiatrist. And so I used to literally fly or drive hundreds of miles to do clinics. And that took a lot of time. It was very inefficient. And so I got really interested in technology as to how do we solve this problem of getting access to care. And I started using video conferencing, which is what we're all doing now. But this was in the days way before you guys were born, when the use of video was, very expensive. Um, I wonder if anybody would like to guess. This is back in the 1990s, okay? So, 30 years ago. How much do you think it might have cost me at the time as a researcher to buy a video conferencing machine that in those days was about the same size as our TVs nowadays? Anybody got any ideas? Just put into the chat how many $1,000 you think a single machine would have cost, but can't do anything like what our phones can do now. Okay, so most people are putting 10, 20, 6,000. Those are all good questions. It was actually 170,000. Um, so crazy amount, okay? Um, so so I actually got a $500,000 grant and bought two machines, and the rest of the money paid for a whole lot of lines and time and things like that. Um, and then basically, I got interested in technology, and I got interested very early on in artificial intelligence, which is what the SSVMS wanted me to mention today. And I actually had a patent on using artificial intelligence back in 2002. So again, everybody talks about AI as being only around the last 4 or 5 years. And that's certainly true of the big companies with the massive data centers now. But the AI has actually been around for 40 or 50 years. And I was using it literally 25 years ago. And what I was trying to do 25 years ago was to examine the language of people who had schizophrenia, which is a serious mental illness, and which leads people to get a bit confused in the way that they speak on occasions. And so I was trying to mathematically to quantify the language of schizophrenia using AI back around 2002, again before you guys were born. So I've always had this interest in technology and an interest in getting care to people at a distance using video. And and that's why I got recruited from Australia by the University of California to come to the University of California at Davis as a faculty member, and that happened in about 2004. And again, you guys may not appreciate this, but the University of California, as a system, is by far and away the best research university system in the world. It's the 10 campuses of the University of California are phenomenal. Now you're all, some of you will be going to UC environments when you go to college, and I think they're all fabulous colleges, all great colleges to go to, and they're also really, really good and really high performing. And from your perspectives, you're going to want to get, you're going to get teaching there and you'll learn a lot. Many of the faculty at the UC system, however, are actually primarily interested in research. And so that's why it has so many Nobel Prize winners and is such a successful system because it's really the best research system in the world with and by many different markers. So again, as a physician, you can see already I've got a whole lot of different jobs, and I'm actually having a very interesting life. I'm living in different countries. I'm working in different systems. I'm having a whole lot of unusual life experiences. And I think that's something you need to think about when you're deciding, what sort of career should you have? Does the career allow you, if you want, to travel and to go to see other countries and to potentially work in different countries? And certainly, medicine as a career is one of those relatively few careers that does allow you to do that. If you want to. Obviously, not everybody wants to, but certainly in my case, it's been really interesting to be able to work in, as a doctor, both in England, in Australia, and obviously in the last 20 years or so here in America. And so this has sort of led to me also getting interested in business. And so Sam, when she introduced me, said that I was the CEO of a company called Async Health, which is my current job. So I actually left UC Davis full-time employment about 3 years ago to form this company. So I'm now actually in the business world mainly, rather than in the medical world, but I'm doing medical things in the business world and have a company that actually provides care for, or creates software, I should say, that provides care for people who have mental health problems. So I've really sort of come a whole circle of, starting with an interest in mental health, deciding to make that decision, then going into the academic world, living in several different countries, and finally, having seen thousands of patients during my career and really enjoyed that side, I've stopped practicing clinically, and I'm now working full time in business, and with the aim of trying to improve the way that care is provided by other types of doctors. Um, Let me just stop for just a second. I've covered some of the areas I wanted to do, but I'm interested if there's any questions from anyone. Gillian, you've got your hand up?
Yes. Hi. Okay, I have two questions for you. So, my first question is because I am interested in research, but I'd also in like biology, but like maybe biomedical. What is your advice for pursuing both at the same time? Like, how exactly has that worked in your experience? And my second question for you is, since you were working in the psychiatry field, what are your thoughts on like how it would like emotionally affect whoever's taking care of the patients? Because like you said, you've seen many children die, and I'm sure that's not an easy experience to go through. So how do you handle that?
Sure. Well, first of all, they're really good questions, Gillian. Um, The let me take the second one first, okay? I mean, one of the things when you go into healthcare is you have to be prepared to have for your work to have significant impacts on you. And seeing people die, or in my case as a psychiatrist, sometimes people suicide, or, I mean, there are other, awful things happen, okay? So one of the things that you have to think about is, okay, what are you like as a person? How strong are you? Are you the sort of person who, can tolerate those sort of stresses? Because, yeah, the downside of healthcare is that not everybody gets better, as you correctly say. And I was pretty shocked by seeing all these children dying of measles. I hadn't really thought of that coming from England at the time. And so I guess I'm lucky in that I'm fairly resilient. But I think you have to think about your own personality. Do you want to be surrounded by people who are sick and who may not get better? And look, some people find in medicine, they go into medicine and they start doing going through medical school, and they actually realize they don't particularly like all of the process of patient care, or they don't like the stresses that it can lead to for you. And so they can still go into other areas of medicine where they have much less direct patient contact, maybe radiology or pathology. So there are other areas where you don't necessarily have to have a lot of immediate contact with your patients. And that's actually how some doctors cope. They prefer to go into different areas. Other people prefer to be right at the front end, in the emergency room. But either way, you've got to always monitor yourself and make sure that you're not getting too stressed out by what's happening around you. And what we normally advise people to do is, particularly when they're young physicians, is to try and find mentors. Try and find people who they can talk to, either colleagues or friends, or people who are experienced, so that and to not be afraid to share their feelings with people. So I think in healthcare you do have to think about that downside. It's a very important issue. In terms of your first question, very briefly, just in terms of research, I mean, there are multiple different paths to getting into medical research, but ultimately, if you want to do, fairly high quality medical research, you're probably going to have to get a PhD. So that's a doctorate in research. Now, I happen to have done both. I've got a doctorate in medicine, my MD, and I've also got a PhD, which I did so that I could continue on doing research. That's a little bit unusual, although there's a number of doctors do that. But ultimately, you have to work out, do you want to give yourself the option of seeing patients as well as doing research, or are you purely interested in research? If you're purely interested in research, you may be better off just to go down the PhD path, in say some area of biomedical sciences. Now, there's lots more hands up at the moment, and also there's I'll take just a quick question from Vanessa on the chat, and then I'll come to the people with their hands up. So Vanessa asked, what sort of ages of patients have I had personally? And in fact, I actually, for the last probably 15 years, almost all of the individual patients I've seen and followed up myself have actually been doctors. Now, doctors need help, just the same as everybody else needs help. Doctors get depression, get anxiety, get trauma-related problems, just as we were talking about from Gillian's question. And so I've actually almost exclusively seen doctors as patients for the last few years. And that's been really, really rewarding from my point of view, because you see people who are usually very keen to get better. And that when you get them better, you know that in fact your impact on them is being multiplied because they're also seeing many patients themselves. And if they hadn't got better, they couldn't necessarily see those patients so effectively and provide such good care. And so in every big city, you'll find there are one or two psychiatrists who tend to specialize in seeing doctors, because doctors also need help. And get mental health disorders just the same way as any other part of the population. So most of my patients, quite honestly, were probably in their 40s at least. Most of them were specialist physicians, and for me that was really rewarding. So I'll go across my screen. I think the next person was probably Ria.
Hi, sorry, I was wondering, I'm interested in psychiatry especially. So what do you recommend doing in high school to further interest in psychiatry?
I think, I mean, the most important thing is to go down the path of going to medical school. And then, obviously to get into medical school, then people tend to tend to work with in volunteer jobs in clinics, try and do relevant jobs. It's fairly unusual to be able to actually follow a psychiatrist because of confidentiality issues. The patients don't tend to like to have students sitting in behind you. But you can certainly do some research with psychiatrists and assist them there, or just learn about more in the mental health area, so that when you actually start writing your applications for medical school and you've maybe gone through a pre-med program, then you've got some experience to say, hey, I like that idea of, and I've actually gone and got this level of experience in that particular discipline. Next one was Hazel, I think.
Hi, doctor. I was just wondering, what were some of your biggest struggles in developing telemedicine?
I think the biggest struggles were actually with other physicians, because a lot of doctors didn't believe that you could have a relationship with somebody over video. The patients have always been fine. Patients actually have always liked this, okay? Patients, tend to have no problems or minimal problems. but other doctors have been the more difficult people. And so I literally spent 20 years trying to convince colleagues around, both in Australia and America, that they should be using video with patients. And then along came COVID, and COVID changed everything because suddenly, the medical practices of many psychiatrists were basically, fell apart because the patients couldn't come and see the psychiatrists personally. And so the psychiatrists had to very rapidly learn how to use video. And as you may know now, in this country, more than a third of all consultations done by all psychiatrists in this country are now done on video. And if you're a psychiatrist in private practice and you don't see patients on video, that's unusual, very unusual, because patients find this a very easy, convenient way of getting assistance.
Thank you.
So, Evita, what was your question?
I was wondering, what do you think was like one of your most like impactful moments that you had while working as a psychiatrist?
So that's an easy one for me to answer. This occurred back in 2009 when it always struck me as being odd that we saw patients on video, but we didn't record the videos. Okay. And then in 2009, just after the iPhone was developed, one of my patients was actually in another state for 6 months and became depressed. And she wanted to be able to have me actually treat her, even although she was in another state and couldn't get to come and see me. And so she actually recorded a video of herself and went literally just her husband got his iPhone out and pointed it at her, and she recorded a 5-minute video of herself showing me how she looked and telling me how she felt. And then she sent that video to me, and I watched it and was able to tell that she'd become, more depressed again. And I got onto our electronic medical record and sent her a change in her prescriptions to the state she was in. And then she changed her meds and within a couple of weeks was feeling much better. And so I was completely convinced by the fact that we should be taking videos of patients and using those to help us treat people. And that's actually what led to me ultimately forming the company that I've now got, Async Health. So if you look at the website for Async Health, you'll see it's a company that does asynchronous video consultations, which was that was the first one I did back in 2009. So that actually changed my career direction. And a final question, I think, from Rohan.
Yeah,
are we up to time, Sam?
So yeah, we have one more question and then we have to move on.
Okay.
Yeah, sorry for being the last here, but thank you, Dr. Yellowlees, first of all, for coming here and using your time to give us this sort of a speech. My question for you is that you've clearly done incredible research on asynchronous telepsychiatry. So as AI tools are increasingly used to analyze and record data to draft clinical notes, how do you think that the combination of AI tools and asynchronous medicine will change the day-to-day workflow of doctors in our generation?
Well, I'm hoping that it will dramatically improve it. I mean, what the company does that I've got is they have AI agents, video agents, interview patients, and the agents look like us. Okay, you can go on the website, you can see examples of the agents we use. But we don't let the agents ask any old question. We actually program the questions because we know what questions we want asking. Where we use, but the agents themselves are AI agents. And we then use more AI in the background because we video record the patient's answers, and we use ambient AI, in other words, listening AI, to then transcribe those videos and to write the first draft of the medical notes. So we can actually save 50% of the clinical time to do an interview with a patient by having the basic interview done by an AI agent and then the ambient AI system doing a lot of the documentation. So we can make life much more efficient for the doctor and for the patients. It means they can get an initial assessment without even needing to make an appointment. They just go online and do it. So it's already
Thank you,
happening.
doctor.
You guys will undoubtedly be affected by that sort of approach.
All
Thank
It's
you.
very
right.
cool.
Well, thank you, Dr. Yellowlees. Please, everyone, thank Dr. Yellowlees for sharing this with us. And if you have additional questions, you can email those to me, and I'll make sure to pass them on, and we'll get those answered for you. So thank you, Dr. Yellowlees.
Thank you very much for asking me, Sam. Appreciate it. And good luck for all of you in your careers, okay? And I think you're making great choices if you go into health.
All right, we're going to move on to our next speaker. So remind me how to say your name. Is it Karis?
Kairos.
Kairos. Kairos is a doula, and she is the executive director of Children of the Sun Doula Project, Inc. She's a member of the co-design team that created the Department of Healthcare Services Medi-Cal Doula Benefit, and 27 years in continuous practice as a doula and doula trainer. So welcome.
Thank you. I am very excited to be here. I have the unique position as a doula to recognize the value of clinical and non-clinical providers working together in order to give our members, our clients, our patients the best experience. So I'd like to talk to you a little bit about birth work, if that's okay. How many of you know what doulas are? I see like 2.5 hands. Great. I will start there. So, the definition of a doula, the word is actually Greek. It means a woman who serves. It was not necessarily a positive reference to the role of a servant. However, as Western world folks, we take a word that we like and we turn it into whatever we like. And so we have begun to call doulas, birth workers, doulas. So some folks won't use that term, others do. In 2026, a doula is a non-clinical care provider who provides emotional, physical support, helping pregnant people navigate healthcare systems. We educate them around pregnancy, physiologic birth, and then we support their vision and their preferences for how they want to have their babies, how they want their pregnancies to resolve, like the experience that they want to have, their parents, their families, all of those things. And if you guys have been tracking much of the perinatal health world, what do I have a hand up? That's so weird. Um, one of the things that has become pretty common in the last few years is to look for spaces where community-based providers can connect to people who need support in from their own communities. In other words, somebody in your neighborhood, somebody from your culture, somebody who lives their life in the space where you do your work. And what has come out of that is perinatal health, community health workers or community health advocates, peer support specialists, which are people with lived experience supporting folks who are needing support with their mental health and their emotional health. And then, of course, the age-old practice of doulas, of birth workers. So often, I will say back in the day, a doula did all of those roles, in very much the same way that you would look at your grandparents' home and see that, this rug that they used to have by the door that, when you were a little kid, you would run by and slide on it and get to the kitchen, but that's a fall risk for your grandparents. And so you say, oh, let's move this rug or let's get a different kind of rug. That's kind of the role of a community health advocate, looking to see what things are needed for a person to be safe, for them to continue to have independence, for them to be able to do life on their terms as much as is physically possible. You may have someone who is a primary caregiver for a spouse. Let's say there's a wife who takes care of her ailing husband, but she's now aging. So then there needs to be somebody to make sure she has the support she needs to be able to continue supporting her husband. Then you have the peer support specialist. It could be anywhere from substance challenges or overuse of things, or depression, or developmental or cognitive challenges that people might face. So that is the role of the peer support specialist. And then for doulas, doing the pregnancy support, the fertility support, the postpartum support, and then that period beyond postpartum, the first year after a baby is born. So when I started in birth work in 1999, doulas did all of those roles, and they weren't separated out. It wasn't a la carte. However, as we have moved forward, people begin to specialize in the parts that they like. Even within the role of doula, a person might decide what they want to do